All right, so welcome back to the discussion on the review of anatomy and physiology of the cardiovascular system. So we're done with the review of it, and now we are heading towards the review of your physical assessment. We'd also, of course, start with the assessment of the general appearance of our patient. So when we are assessing patients for those of with cardiovascular disease, we take note of the assessment of their build, appearance, the skin color as well for the integumentary system, the stress level, level of consciousness. Some patients, you may have to assess the presence of shortness of breath, the position when you conduct the interview, because this may um, explicit the patient's ability to breathe continuously without difficulty as he or she talks, as well as the verbal response of the patient for the appropriateness of their answer. Take note of the decrease in cerebral perfusion may be caused by confusion, memory loss, and leading also to slowed verbal responses. For those patients who are having chronic heart failure, they may seem to be malnourished, looking thin and cachectic. When we do say cachectic, it is extreme loss of weight or thinness because of the absence of um, micronutrients onto the patient's body, leading to poor development of the muscles. Late signs of severe right heart failure may include ascites or accumulation of excess fluid in the abdomen, jaundice, anasarca. When we do say anasarca, it is a generalized body edema, and of course, edema to several parts of the body. For the integumentary system, it is mentioned earlier that we look onto the skin color of the patient. Normally, of course, it is pinkish, or for those patient, even for those patient who are on the darker color. So make sure it is pink, warm to touch. And if there would be some problems in terms of the decrease in the perfusion, patient's skin may be cold, pale, and at times moist skin. Take note of their nail beds, for it may appear with the presence of cyanosis. When we do say cyanosis, again, it is a bluish discoloration of the skin of the patient. Check also the palms of the patient, the conjunctival mucous membranes. So your cyanosis could be classified into two. It's either your central cyanosis or peripheral cyanosis. Central cyanosis are considered of the discoloration of the lips, the tongue of the patient. And when we do say peripheral cyanosis, it may involve the extremities of the patient, both upper and lower. Take note also that some patients may be developing dusky redness or rubor, which may be an indication of arterial insufficiency. Check for the skin temperature and assess for the symmetry of the temperature, both comparing to both left and right. So, at the distal portion of the extremities, we should check the patients if they may be having clubbing. So, we know that clubbing is an increase in the size of the nail beds because of the lacking or chronic oxygen deprivation in the tissue beds. So, these are advanced chronic, seen in those patients with advanced chronic pulmonary diseases, congenital heart defects, and sometimes cor pulmonale. Peripheral edema may be seen not only onto the extremities of the patient but also to the trunk. We should take note for the extremities, bilateral leg edema, which are usually seen in patients with heart failure or chronic venous insufficiency. Abdominal and leg edema may be an indication of heart diseases or at times liver cirrhosis. Localized edema can be seen, for example, in one of the legs of the patient or at times at the buttocks, at the legs. So maybe an indication of a venous obstruction or a thrombosis or a lymphatic blockage, also known as your lymphedema. Dependent edema, of course, seen in those patients who may be having heart failure, usually caused by the pull of gravity and seen usually at the lower part of the body. Third spacing edema is an indication of the absence or the decreased levels in the albumin or your plasma protein. We take note that the plasma proteins are the ones maintaining the oncotic pressure, therefore preventing the movement of fluid from the intravascular space to the third space. And of course, it can be graded to either mild, moderate, or severe edema, or better known as 1, 2, 3, and 4. Edema could be classified to either pitting or non-pitting. When we say pitting edema, when there would be an indention upon palpation or pressure onto the specific area of edema. When we say non-pitting, there would be absence or no indention after a little or light pressure. This is an example of a pitting edema wherein a presence of indention is seen upon palpation of the healthcare professional. The indention is measured with grade 1, grade 2, 3, and 4. So these grades indicates the depth of the indention measured in millimeters. If it is grade 1, there could be a mild pitting, slight, meaning there is a slight indention of no perceptible swelling of the leg, and usually the indention is about 1 to 2 millimeters. Grade 2 or plus 2 is a moderate pitting. Indention subsides rapidly. The measurement for the indention is about 2 to 4 millimeters. If it is 3 to 6 millimeters, it is termed as or called as grade 3, which is also indicate a deep pitting. An indention remains for a short time and the legs look swollen. And if it is about 7 or more, there would be a very deep pitting edema. So the indention usually lasts for a long time and the leg is seem to be very swollen. This photo at the left upper portion of the screen is an example of your clubbing. As you can see, there is an increase in the size of the nail bed as a compensation for the decreased or chronic deprivation of oxygen. We take note of the blood pressure of the patient as well, and we know that the normal blood pressure is when the systolic blood pressure is less than 120 millimeters mercury and a diastolic pressure of less than 80 millimeter mercury. If the systolic pressure usually increased at 120 to 129 and the diastolic is between 80 to 84, it may be considered that the patient is having high normal blood pressure. It is not yet considered a hypertension, however, just a little bit higher than the average or the normal average blood pressure. Prehypertension can be considered when the patient's blood pressure falls between 130 to 139 millimeter mercury for the systolic and the diastolic pressure of 85 to 89 millimeter mercury. Usually, these patients with prehypertension have a higher risk or chance of developing hypertension. And of course, hypertension is considered when the blood pressure of the patient falls more than 100, more than or equal to 140 over 90 millimeter mercury. This is a new classification of the categories of the blood pressure according to the American Heart Association. So the normal is less than 120 over less than 80. It is considered to be elevated if the blood pressure falls 120 to 129 over less than 80. And a high blood pressure or hypertension stage 1 is considered to be 130 to 139 of the systolic and between 80 to 89 of the diastolic blood pressure. Stage 2 hypertension is considered when the blood pressure increased to 140 millimeter mercury or higher with a diastolic blood pressure of 90 millimeter mercury or higher. A hypertensive crisis is considered when the blood pressure of the patient falls higher than 180 millimeter mercury over 120 millimeter mercury. We can take note that there is a slight difference between the measurement of the two blood pressure categories that I have presented. So this is an update from the American Heart Association. However, according to the Philippine Heart Association, they are not yet adapting the classification of the AHA since there could be some differences in terms of the um, racial contributory factors of the Caucasian between Asians and specifically Filipinos. So we all know that the blood pressure can be effectively controlled with lifestyle modification, including your medication. If the patient's blood pressure is less than 90 over 60 for adults, there could be an inadequate for proper and sufficient nutrition of the body cells. So there is also what we call as your hypotension, wherein there is a low levels of blood pressure. So usually it is less audible or absent carotid cough sound for those patients with or having shock or hypotension. If in that case we may use your Doppler device for us to be able to listen or auscultate the Korotkov sound. At times, patients' palpatory blood pressure should be taken if there is no audible Korotkov sound. Usually, we do take only the diastolic pressure, or sorry, we do only obtain the systolic blood pressure and the diastolic blood pressure is not obtained. Usually, this is done to those patients who just had a cardiac arrest or during a code blue. Blood pressure should be maintained all throughout. However, there could be blood pressure can fall based on the sudden movement of your patient or fall down with the pressure. It is termed as your postural BP. So BP is not adequately maintained while moving from a lying to a sitting position or a standing position. Usually there could be a decrease of more than 20 millimeter mercury of the systolic blood pressure and more than 10 millimeter mercury of the diastolic pressure, which may range about from 10 to 20% increase in the pulse rate. So, how do we determine if the patient is having an orthostatic hypotension? We usually measure the blood pressure when the patient is lying down supine on bed for about 3 minutes. So we take the blood pressure and after we change the position to either sitting or standing position, then we observe for any changes in the signs and symptoms of distress, which may include lightheadedness, um, dizziness, or at times nausea and vomiting. There is a what we call a paradoxical blood pressure. It is when an exaggerated decrease in the systolic pressure happens, usually more than 10 millimeter mercury during inspiration. So we have to measure the difference between the systolic and the diastolic blood pressure, and it is termed as your pulse pressure. The normal difference between the two is about 30 to 40 millimeter mercury. So if it is narrow, when we do say narrow, it is less than 30 or usually 20 millimeter mercury. means that there would be an increased peripheral vascular resistance or decrease in the stroke volume. Usually seen also in those patients who are or who sustained internal bleeding. An increase in the pulse pressure may indicate also slow heart rate, aortic regurgitation, atherosclerosis, hypertension, or at times brought to us by aging.